So, first of all, I will request Dr. PARUL CHAWLA GUPTA to speak on the basic steps of pediatric cataract surgery for the beginners.
A very good afternoon to all. Today we'll be discussing the basic steps of pediatric cataract surgery for a novice pediatric surgeon. So congenital cataract has a worldwide prevalence of around 4.24 per 10,000 people, with the largest prevalence found in Asia. It is one of the most important treatable causes of childhood blindness. So what should be the timing of cataract surgery? To prevent stimulus deprivation amblyopia, dense, visually significant bilateral congenital cataracts, the surgery should be done around 6 to 8 weeks of age. And for unilateral, visually significant cataracts, it should be done around 4 to 6 weeks of age. In fact, now they recommend around 6 weeks of age because the vision before that is mediated subcortically. So it won't make a difference whether you operate at 4 weeks or 6 weeks. In fact, the younger the age that you operate, more will be the chances of glaucoma. So increased rates of post-operative glaucoma in the first 4 weeks of life is seen in literature. So that is why we prefer to operate after 4 weeks, that is around 6 weeks, especially in unilateral cataracts, and bilateral can be delayed even later. So I'll just give a brief account of biometry. It will be discussed in the future presentations also. So axial length can be measured using an immersion or contact A scan or using B scan ultrasonography. And while using the contact A scan values, the value with the maximum anterior chamber depth should be chosen to offset the inadvertent indentation of the cornea with the A scan probe. Keratometry values can be obtained using an autokeratometer. It can be handheld. Reading should be preferably taken without using the eye speculum and thereby avoiding the compression of the globe. Optical biometry with IOL master or lens star can be carried out in older cooperative children. So intraocular lens power in children should aim for moderate hyperopia postoperatively to compensate for the myopic shift which is expected in children due to axial elongation of the globe. And IOL can be implanted in eyes with an axial length of more than 17 mm and corneal diameter of more than 10 mm. SRKT and Holiday 2 formula give the best postoperative outcomes in pediatric eyes with axial length less than 20 mm. And in the IATS study, that is the infant aphakia treatment study, Vanderveen et al. Have shown that SRKT and Holiday 1 have the least prediction error in children. In a study by Dahan et al., we can also do 20% undercorrection in children less than 2 years and 10% in children between 2 to 8 years. In fact, another study by Prost has suggested 20% undercorrection in less than 2 years, 15% in 2 to 3 years, and more than 4 years, 10% undercorrection. So there was a recent study by Chang et al. In 2020 which compared 8 formulas in less than 8-year-old children, and SRKT and was the best in axial length less than 21 and age less than 2 years. And the Barrett's and the Hagees were best for age group more than 2 years and axial length more than 21. So this is one video which I'll be showing you. Can you increase the sound? So after making the side ports, we inject the trypan blue dye. To discuss in detail, the incision, it can be a superior clear corneal triplanar incision of 2.2 mm or 2.8 mm, which is preferred in children, as the wound is protected by the upper eyelid from trauma. Scleral incisions 2 mm from the limbus with conjunctival peritomy are rarely used these days unless we are using a rigid PMMA lens. Smaller, tighter fitting incisions help in better maintenance, AC maintenance, and stability of the anterior chamber. They minimize the times in and out of the eye. And two uniplanar 1 mm incisions approximately 180 degrees apart give better maneuverability. This is for the side ports. So 2.2, 2.8 for the main port and 1 mm for the side ports. So to address smaller pupils in children, small pupils less than 4 mm in diameter lead to a higher rate of complications. Posterior synechiae can be due to uveitic cataracts, traumatic cataracts, persistent fetal vasculature, and pupillary fibrosis. So we dilate the children pre-op with tropicamide 0.8% and cyclopentolate 0.5%. And 1 in 1 lakh preservative-free adrenaline can also be used intra-op, and nowadays we are using phenocaine, which is a combination of tropicamide and lignocaine in order to dilate the pupils of children intra-op. So why anterior capsule rhexis is difficult in children? So children have a capsule which is thinner and elastic. It is convex shaped. It can tear easily and easily run peripherally. And the AC is shallow and the eye is also shallow. IOP is lower because there is less rigid sclera and easily collapsible. And poor red reflex might be there due to the opacities. So anterior capsule rhexis can be done by various techniques. We can use a curvilinear capsulotomy. We can do it with a vitrector, that is a vitrectomy cutter, that is known as vitrectorhexis. We can use a 2-incision push-pull technique in which we give 2 opposite incisions on the capsule rhexis and then extend them circumferentially. We can also use the 4-incision technique in which we give 4 incisions in each of the 4 quadrants with the cystitome and then join them all together. We can also use a femtosecond laser assisted capsulotomy technique, and we can also use a plasma blade or a fugo blade for capsulotomy or intraocular diathermy, and precision pulse capsulotomy or the Zepto. So what we use most commonly is the curvilinear capsulotomy, the vitrectorhexis in case of fibrotic pupils, and we also use femtosecond laser assisted cataract surgery, which Professor Jagatram has done in a series of patients. So initially we stained with the trypan blue dye, which is 0.06%, and this makes the capsule rigid and stiff. Anterior continuous curvilinear capsule rhexis is done with a cystitome and followed up with a utrata forceps. It should be smaller than the IOL optic diameter. So usually the IOL optic diameter is around 6 mm, so we make it around 5 mm to prevent shallow AC and post-operative pupillary capture. So anterior capsule rhexis is around 5 to 5.5 mm and posterior around 4 mm. And vitrectorhexis is very quick and simple, done with a vitrectomy cutter and used in fibrotic capsules. So we prefer to use a cohesive viscoelastic, that is a high molecular weight ophthalmic viscosurgical device. It flattens the anterior capsule and keeps the anterior capsule taut. And it also counters the effect of low scleral rigidity and vitreous upthrust. So this is a picture of the cohesive viscoelastic which stays there and maintains shape, and this is a dispersive viscoelastic which doesn't maintain shape, it just coats the endothelium. So we prefer a cohesive viscoelastic in children because the capsule rhexis tends to go to the periphery. So what are the tips for anterior capsule rhexis? We need to pull the capsule rhexis margin centrally. That is, we hold close to the margin where it is tearing, and with the utrata forceps we try to pull it centrally and at around an angle of 45 to 90 degrees. We use a cohesive viscoelastic as discussed, and we take frequent bites of the anterior capsule. We keep on catching hold of the capsule where it is being torn. Multi-quadrant hydrodissection is done using a cannula mounted on a 2 cc disposable syringe filled with a BSS. At least 3-quadrant hydrodissection should be done to facilitate easy lens matter aspiration. And coaxial or bimanual irrigation aspiration handpieces can be used. We start from the periphery and swipe clean all the cortical matter. It is essential to polish the capsule also because the remnant anterior lens epithelial cells can proliferate and migrate and lead to different forms of posterior capsular opacification. IOL implantation. The anterior chamber is filled with high viscosity viscoelastic. Push the leading haptic, that is the first entering haptic, underneath the anterior capsule, and then push the trailing haptic into the bag using a Sinskey hook. Single piece hydrophobic acrylic IOLs are preferred for in the bag placement. This leads to less posterior capsular opacification and pigmentary deposits on the IOL because the haptics will be placed in the bag and they will not continuously rub against the iris. 3-piece IOL, but sometimes 3-piece IOL can also lead to inadvertent posterior capsular rupture, so we need to be careful. Monofocal IOL is preferred in children. However, multifocal IOL can be implanted in children more than 5 years of age with bilateral cataracts. So what should be the lens material? Silicone, if we use a silicone material lens, then it can lead to silicone oil deposits if in case there is a posterior segment surgery. It can lead to calcification with asteroid hyalosis and opacification with the air fluid exchange also. So all these complications take place during the retina surgery. So we should avoid a silicone IOL. Hydrophilic acrylic IOLs, they lead to late opacification and calcifications. They also absorb the dyes. That is, you might see a blue lens in the eye. So you might wonder what it is. So that probably is due to the hydrophilic acrylic material which has absorbed the blue trypan blue dye and given it a blue color. They also sometimes absorb the canacot or the triamcinolone deposits. The hydrophobic acrylic are the best materials to use. They are less likely to opacify. PMMA, they are not foldable, so we need to give a large incision, but they are stable in the sulcus, so they can be considered in case of any complications. Peripheral iridectomy is a must in patients with aphakia or in patients with uveitic cataract or traumatic cataracts, and it can be done with a vitrector. And if the site bleeds, you can just put intracameral air, or you can put adrenaline or even viscoelastic tamponade, and then wash away the viscoelastic later on once the bleeding has stopped. So primary posterior capsulotomy and anterior vitrectomy is very essential because PCO is the most frequent complication occurring in such children. Considerable risk of visual access obscuration and amblyopia in the children occurs in patients who haven't undergone this posterior capsulotomy and anterior vitrectomy. So it is, the risk of PCO is 100% with an intact capsule. So we use the cut IA mode, that is cut irrigation aspiration mode of the cutter, and we cut the capsule. And this is done in patients less than 8 years of age, or mentally retarded children who are even more than 8 years of age, or those having nystagmus, because they won't be able to sit on the yak cap slit lamp machine. So posterior capsular rhexis should be kept a little smaller than the anterior capsular rhexis, and posterior optic capture can also be done for preventing the posterior capsular opacification. So posterior optic capture will be, the optic will be behind the even the posterior capsular rhexis, and the anterior and the haptics will be between the anterior and the posterior capsular rhexis. So the optic will be behind and the haptics will be in between in the bag. So suturing should always be done, especially in children less than 2 years of age. In fact, they say less than 1 year of age, because of low scleral rigidity, increased elasticity, and more vitreous upthrust in children. AC keeps on shallowing. So we need to suture the wounds in order to prevent shallowing and prevent future post-operative anterior sanique, peripheral anterior sanique. So it is imperative to suture all wounds with either 10-0 nylon monofilament or 10-0 Vicryl and prevent anterior chamber collapse. For children more than 2 years of age, it can be left sutureless but with proper wound hydration. This decreases the surgical time, avoids suture-related complications like loose sutures and debris collecting on sutures, and decreases need for repeated anesthesia for suture removal, and also decreases the incidence of end-off. So basically under 2 years of age we need to suture, and more than 2 years of age we can leave sutureless provided we have hydrated the wounds properly. Preservative-free moxifloxacin can be given intracamerally, and subconjunctival dexamethasone can be injected to decrease the post-operative inflammation. Follow-up can be done with topical corticosteroids 6 to 8 times per day, tapered over a period of 4 to 6 weeks. Topical antibiotics should be given around 4 times a day. Topical cycloplegics like homide or even tropicamide can be given for 10 days to 2 weeks in uncomplicated cataract surgeries. And follow-up we do with periodic glasses or contact lens in cases of unilateral aphakia, and patching for visual rehabilitation to prevent amblyopia. So this is the last video. With a 15 wash
Thank you, Dr. Parul.